I'm going to take this opportunity to recognize teams leading outstanding work in learning communities. And first, we're going to be highlighting one poster in special recognition of the presenter's outstanding contribution to this year's conference. This is also an opportunity to recognize the vital contributions of patient partners. So here is a lovely patient partner standing next to me, which is Jenny Artsen. Did I pronounce that right?
Well done.
She said, good, well done. I want to make sure I'm pronouncing the names right. So here I'm going to leave this over to Jenny, who had the poster on evidence-based cost accounting, who's going to speak with you for a little bit here. Thank you so much, Jenny. Over to you.
Thanks, Victoria.
Mic one.
Okay, we got it. Okay, I got 5 minutes. Go. The problem to be addressed. We brought my mom home in 2021. She was aging out of the mental health group home system. She turned 91 when she moved home with us. And we had no idea what we were getting into. And there was no system in place that would prepare us for what we were going to do and to support us as we went through the process of bringing my frail elder home. So the problem to be addressed is this lack of infrastructure, formal infrastructure to support the work that's being carried out in family homes that's actually replacing care work that's being done in institutional settings. And what I kept hearing was that it costs less. But actually what I kept hearing from the family caregivers themselves was it costs less for who and how. So this work was inspired through my conversations with people from the BC Support Health Unit, actually, where I submitted a question to SPORE Evidence Alliance to look into what do we have for evidence-based data that shows the cost of operating a long-term care bed at home, in your family home. Where is the evidence-based data that supports what it costs in terms of time and materials? So I submitted the question and it got funded. So that's what I'm working on right now with a team from UBC in health economics. And we have pulled down 3,700 studies and out of those 3,700 studies that had caregiving, home support, long-term care, the keywords in it, we actually were able to pull 37 out of that collection that mentioned cost accounting for family and family caregiving in some degree. And I'm yet to find a paper in the study that I've been working on that makes the study of family caregiving the primary focus of the research, and that it is evidence-based. It isn't just having someone fill in a survey and answer a question about how many hours do you think you're working, or how much do you think this costs, but actually studying the real time and the real material costs of family caregiving. So our goal with this project is to be able to find out what are the cost accounting categories that are used to quantify the cost of providing a long-term care bed in an institution, and then how can we take those cost accounting categories and apply them to family caregiving settings so that we can have something that can be compared between the institutional bed and the family care bed. Right now we have no cost data to say whether it costs more or less. In 2017, it was reported that it cost $75,000 a year to operate a long-term care bed in an institution. Here's me operating a long-term care bed in my home, and I'm saying, wow, if they would just give me $50,000 a year, I could easily survive the work that I'm doing. What we do know about caregiving is that the needs increase over time for care recipients. At the same time, the socioeconomic vulnerability of the caregivers, it increases in that their resources go down. So their vulnerability increases at the same time that the The care recipient needs are also increasing, and it's extremely difficult for families. And so that's the work that we're doing right now with our scoping review, and we haven't found any studies yet. So my last pitch is, if anybody has any power to put into a research program an agenda to prioritize the cost of caregiving in family homes so that we would actually have some numbers to use, I think that would be an incredibly powerful thing to do to improve health outcomes in health.
Yes. Great. Thank you so much. Thank you, Jenny, for your outstanding work to support people in long-term care. Thank you. Okay, everyone, I would like to introduce 3 teams who are invited to present their posters. First, we're going to hear about Project Impact, patient-centered care in pediatric type 1 diabetes using texting spreading in interior health. Please, everyone, give it up for Project Impact.
Thank you very much for this opportunity to present our work that really was birthed out of a desire to meet patients where they're at. My name is Aiko Waida. I'm a pediatrician based out of Vernon Jubilee Hospital in Interior Health. I'm standing in for our patient partner who could not be here with us today. I'm co-presenting with Maddie Brower, who is a dietitian and project coordinator. And we come to you from the traditional unceded ancestral territory of the Syilx people. And as you can see on the slide, we are but a small part of this very large multidisciplinary project. And it really is enhanced by the varied expertise level and lens of many, many different people, not just facility-based, but also in our community. The secure text messaging platform that we're using is WellTel, and Maddie and I do not have any financial ties with this company. So I consider type 1 diabetes in pediatrics to be a wicked disease, and it's wicked for a number of reasons. First of all, it's costly. It's primarily diagnosed in childhood, and the annual incidence is rising about 3% a year in British Columbia. It is a disease now that is very technology driven. Most of our children now are on insulin pumps and are on continuous glucose monitoring devices. And the patients need expert support from a very small group of clinical teams to make this all work. But these teams tend to be located and scattered in different locations. And finally, diabetes itself in childhood is a very complicated disease with multiple factors that affect glycemic or glucose control. So Diabetes Canada recommends that as clinical care teams, we see children and families 4 times a year to provide excellent glycemic control, 4 hours a year. And the expectation is that families reach out to us if they need help, advice in between. But the reality is that it's not happening for a number of reasons. And so what happens? We see often chronic suboptimal glucose control. So as a care team, we thought, well, what can we do to support our families better, but with no additional resources? And we thought maybe we could provide secure text messaging as a way of providing that care. So we've actually changed our mental model of care. Instead of saying, call us if you want help, reach out to us, we're actually now inviting them to be involved. We're inviting them by sending out weekly text messages. And these text messages alternate from, for example, a joke, which our young patients love, or we might send them an educational tip, or we might send them a thought-provoking question. You know, heat waves cause higher blood sugars, for example, and we offer some advice around that piece. Or we might provide some positive affirmation because this is a hard chronic disease. So I'm just going to pass the mic over to you, and Maddie will just talk to you about our learning community and how we're using texting, which is a communication modality that has been endorsed by the International Society for Pediatric and Adolescent Diabetes in their 2022 guidelines.
Thank you, Aiko. Okay, so now you know a bit about our project. Let's talk about our patient partners or our learning community. So the value of the patient voice actually predates this project. Dr. Wida met with some families that were connected to our clinic and did some process mapping. And it was during this that the need for better communication between the clinic and families was brought forth. So the importance of the patient voice continues into phase 1, where we started texting with a subgroup of our clinic, 17 teenagers. To get the patient perspective, Dr. Wida did in-person and telephone interviews with participants. So phase 2 of our project was expanding the use of texting beyond that group of teenagers to the entire clinic. So we're now using texting with caregivers and youth ages 10 to 19. Our learning community grew as I was added on as project coordinator at this time. And through email, and now our new modality of texting, we were able to recruit 4 members to join our patient partner committee. So we had 3 mothers of youth living with type 1 diabetes and 1 teen who lived with type 1 herself. We would meet quarterly in person at a cafe or by Zoom, and these meetings were always planned for an hour, but would most often go much longer due to such rich discussions. So phase 3 of our project was again expanding the use of texting, but this time beyond just the Vernon Clinic to other clinics in the region. Our learning community grew again as Jackie, our project manager, came on board. So each of the sites delivering diabetes care in the region has unique needs. So it was a no-brainer that we needed to include a patient partner from each of these new spread sites. We also realized at this time that we should give our patient partner committee a formal name. So we went with Patient Family Advisory Committee, or PFAC. So we were able to recruit members from 2 of the 3 spread sites, and we have been meeting all together, our new PFAC, quarterly since May. So our PFAC's primary overarching focus is to explore ways that we can utilize texting to better support families with their diabetes management. We have collaborated on several things together throughout the project. Just a few examples are mental health surveys that we give out to families, other mental health resources, our informational and consent materials. So when we were trying to recruit for our regional PFAC, our Vernon patient partners actually created the recruitment materials. And then a lot of our discussions have shaped many of our processes, in particular, the content of those check-in messages that Aiko showed you. So at our last meeting, one of the parents said they would like more positive affirmations. So this is our attempt at trying to implement that. And quite honestly, whenever our core team is faced with a dilemma, we will often run it by our PFAC just to get their opinion, and it's proven to be very valuable. So we are extremely lucky to have such an engaged PFAC working on this project with us. I really feel that by being so collaborative, it has not only enhanced but helped maintain engagement within our learning community. We do fairly steadily keep in contact, be it our newsletter or just email communications. I think that by offering flexible meeting times and virtual options, that's also promoted engagement. And then to show our appreciation for their time, we always do a gift card after meetings. I'm going to pass it back over.
So in terms of sharing our knowledge, as Maddie referenced, she spearheads a quarterly newsletter that's actually sent out to the PFAC, our supporting foundation donors, as well as our regional teams. We've made several presentations internally in Interior Health, including the Person and Family-Centered Care Committee, who's very interested in our work. Our project is highlighted within the Internal Interior Health website as a project that is that is aligned with the Interior Health's new strategic plan of providing patient-centered care that's driven by innovation. And finally, there's a picture here of our engagement forum where we brought all 4 sites together for a day of learning and sharing. It was attended by the VP of Quality, Research and Medical Affairs and Academic Affairs, as well as the Executive Medical Director of Quality. And our patient partners played a very key role in that day. They were integral to the presentations. They presented on the PFAC. And the clinical sites were very, very moved and motivated to keep doing this work based on the stories and the information that they received. Lessons learned, lots of lessons. First of all, number 1, do not make assumptions as clinical teams that you understand what matters to patients. We must ask. From a process standpoint, we found that it's very valuable to have a point person if you're having multiple patient partners to ensure that meetings are set up in a way that is respectful of their time, as well as to ensure that the communication is crisp. Having patients involved has actually made us step back and ask us why we do the things the way we are doing them. Do we do it this way because that's the way we've always done it and it's convenient for us as clinicians, or is it because it's best for patients? Our clinicians have experienced more joy in their work, and that's actually really critical at this time when healthcare frontline staff are quite burnt out. If you have burnt out staff, you have poor quality. And our patients and our clinicians are very engaged in the work that they do. The other thing that we've noticed is that there's been a leveling of the hierarchy. We call each other by our first names. It is a very open communication. Comments are received and they're considered to be an addition to the pool of information and knowledge within our system, and we build on it. It's that diversity of voice that is so critical to how we think about building out our systems. And finally, we have really benefited from the rippling effect of having patients involved. We now have a type 1 diabetes hub in our North Okanagan where patients and families have come together to create a support system where clinical teams are involved. And basically what it's done is it's created an activated agency amongst our patients and families, which I think is incredibly important as we think about health system design. So thank you for all of you for listening, and we thank the various funders that have supported this project and believed in the importance of patient care as we move through some difficult times.
If we could just have a photo with you two, if that's okay. We'll have a quick little snap. I'm just going to stand over here. Great, awesome. Before we move over to the next group, can everyone just repeat after me with a shimmy and a sound? So that was okay. Okay, okay, again, go. Now look to the person next to you and now shimmy at them. Okay, we're getting there, It's okay, it's okay. Okay, our next group is Get the Message. This next team, improving access to virtual healthcare for older adults through patient-partner collaboration. Thank you so much. Clicker, Mike. This is them. Yes, thank you. Embrace mistakes. Okay, do you need a mic as well? Yes, great. And then here's the clicker for you as well. That's her. Oh, okay, okay.
Can you see? Okay.
Hi everyone, thank you for joining us today. My name is Quinn. I'm with the Research and Evaluations team in the Virtual Health Department at Fraser Health. And I'm joined here by Kim, who is one of our wonderful patient partners that we collaborate with in our research projects. So for our presentation, we'll walk you through the how and why our research team decided to collaborate with the community to improve the virtual health healthcare access for underrepresented populations. So with the onset of the COVID-19 pandemic, the adoption of virtual health services has significantly increased and became a key component in healthcare delivery. And while the sudden shift brought out many challenges, it also provided us with an opportunity to think more inclusively about who we want to engage with when shaping healthcare delivery. So as part of our pandemic response, a working group within our virtual health department was established, and this group consisted of several patient partners. And as this initial collaboration began to expand, it became clear that we needed a more structured and formalized approach to patient engagement. So this led to the development of engagement guidelines as well as patient-oriented research grants with the patient partner committees. And within these guidelines, we also developed a patient partner toolkit with the patient partners, which is also available for you to review via code at the corner there. But this guide basically covers the basics of patient engagement, including why it's important, how you can engage with patients in your own project, different forms of engagement, anything to keep in mind, and any additional resources for further support. Over time, with the structured guidelines and the ad hoc committees, this evolved into what we now call our Patient and Family Advisory Council. So this brings me to our current initiative called Get the Message, which is a research program that is aimed at improving the accessibility and effectiveness of patient-to-provider messaging for older adults. And this can include any form of virtual written communication, including text messages, emails, or anything patient portal related. And because despite the widespread adoption of virtual health services and its many different advantages, older adults still face much more barriers in receiving these types of care. And their perspectives are often underrepresented in research and evaluation of virtual health programs. So through Get the Message, we're working to identify and remove these barriers to ensure that virtual health services are accessible and user-friendly for our older patients. And to achieve our objectives, we're collaborating with a team of 5 dedicated patient partners who are community members themselves, either being older adults or caregivers to older adults and who have gone through the healthcare system. And our patient partners work with us at every stage of the research, from design to implementation and to analysis. And this could look like developing or reviewing and providing feedback on documents such as study protocols, study proposals, or interview guides, identifying any needs or gaps in research, or identifying any data collection sites and methods. And as we currently enter the knowledge translation stage of our research, patient partners will help us determine what outcomes are most relevant and meaningful to the community, while also ensuring that these findings are presented in a way that aligns with the community's preferences and needs. And our patient partners bring in a unique perspective that research alone cannot provide, so we want to include their perspective and inputs in any way that we can, including for our poster for today's conference. So as you can see, the drawing in the middle of the poster is something that we created with an illustrator who actually sat in during one of our patient partners meetings while we were discussing the importance of patient partners' roles in research. And the illustrator captured the themes from the patient partner's perspective and drew out this wonderful graphic recording that highlighted the benefits and challenges that comes with patient engagement. So by involving the patient partners into our research projects, we're including the voices of diverse patient populations, especially those from marginalized or underserved communities, and by applying these insights, we can move toward a more equitable healthcare system where effective communication can contribute to a better health outcome. And that was just from the research point of view, so now I'd like to hand it over to Kim, who will share her experiences and let you in from the patient partner's perspective.
Thank you, Quinn. And I'd also like to say thank you to all of you for standing up here with me. With all the patient partners we have here today and all the other experts, it's nice to see that accommodations were made for me so that I don't feel, kind of noticed I wouldn't be able to get up on the chairs and talk to everyone. So it's kind of nice to see that I'm supported here. I'm not up here by myself, and I feel part of the team. When I was asked to come here today, actually, I was a little bit nervous because I thought, what do I have to offer? And I came here and I was just so surprised. It's my first time at a conference like this. And when I got here, the first thing I noticed that I was treated as an equal, people didn't ask, are you a patient partner? Do you do this? Do you do that? Or are you an OT or a PT? The reason I say that is because when I was first injured, I broke my neck right after high school graduation. That was 35 plus years ago. And I remember when I was going through the rehabilitation process, we would be in a team meeting, and they would have regular team meetings throughout the rehab process. And just as is typical in the hierarchy, I'm so glad things have changed in this concept of lived experience, community engagement. Nothing about us without us has finally taken hold, because when I was first injured, it was quite common where there was a hierarchy. When we would have the team meetings, we would have all the practitioners from the various departments, but without a doubt, the team meetings always started with the doctor coming up with goals. I think you know where I'm going with this. The next was the physiotherapist, then the OT, then the social worker, then the rec therapist, and then maybe someone like me at the end. And it always kind of seemed odd to me that the team would be there making goals for people rather than with. And I've seen a huge shift in 35 years. It just always seemed odd to me. Why would you make goals for people rather than with them? And it's really nice to see that shift in attitude in the healthcare system over the last few decades. The reason I got involved with this is when I became semi-retired recently, I became involved. I had more time and I wanted to give back. And I knew that I had a lot of life experience that might be of value to others. So I started with working with the Praxis group. Praxis is a nonprofit organization that leads global collaboration in spinal cord injury research, innovation, and care. And when I started to get involved with projects like that, once you get involved in research, it tends to just spiral. One of the things I noticed in being involved with the research was that it sort of seemed to be the same group of people involved all the time. And it occurred to me that there's a group of people out there that have significant barriers, and we want to reach those folks. How do we get to those folks? So the people who were being involved in the research projects tended to be people who had access to a phone, a computer, the internet. I think a lot of times we just take for granted that people have access to phone and internet, but when we're thinking about certain groups of people, especially the hard to reach groups, we really need to consider, how do we access that group? So once I got involved in that, I ended up, through that collaboration, I ended up getting involved with Fraser Health about a year ago, and they asked me if I would like to be involved with the virtual health program, the hospital at home, virtual hospital. And nowadays, when I go to a meeting with Fraser Health, I don't even know which meeting I'm at because I'm so involved. It tends to spiral like that when you get involved, but I wouldn't be here today if it wasn't for the fact that I felt that my engagement was meaningful and that I was treated with respect and as an equal. So I have a feeling I'm going to be involved a lot longer with Quinn and Fraser Health. And I really appreciate the respect that I've been given so far, and whenever I have a question, Quinn gets back right away. But it really is a true and meaningful partnership, and I think that's key. I've been involved in some projects where it really feels like tokenism, check a box, have you involved somebody with lived experience, but in this case and these programs, it's really meaningful, and because of my experience working with people hard to reach communities, I had a couple of concerns with switching, or I thought it was switching, but what we're really looking at is options to provide care virtually. But my first thought was, what about those hard to reach populations? We don't want them left behind. So I wanted to make sure that I was a voice for that community, and that I was maybe hopefully able to connect with some of those folks, because sometimes when you're reaching out to a hard to reach community, you can find peers in the community who might sort of be seen as leaders, and they can often help make that connection with other peers in the community. As far as the hospital at home program, the reason I became so enthusiastic about that is because I had spent an extended time in acute care. Over the last 10 years, I was admitted into acute care because I was septic twice. Yeah, I was a little surprised that I ended up, some people really don't like hospitals. In my case, it took becoming unconscious to end up in the hospital to realize I really needed the help. There are people out there who really don't like going to hospitals. In my case, you know, twice lucky. I don't know if I'll be third time, so I don't know if I'll take that chance in the future. The first time I had, turned out was appendicitis, a ruptured appendix. And I think I'd been sick for probably 3, 4, 5 days. And I went to lay down in my bed, and I thought, you know, like, maybe things just aren't feeling right. Something, I don't know, I think there was an angel watching over me, but I decided to phone my doctor, and I have a great relationship with her, so she called back right away, knowing that it wasn't like me to make phone calls. And I was so fortunate because when she phoned back, I was actually so delirious I didn't even understand a word she was saying. And at some point during the conversation, I don't remember anything until I woke up in the hospital several days later. The second time was about maybe 5 years ago. It started with a kidney stone that became septic over time, probably maybe 3 weeks. I don't know, I went on a cruise and I shouldn't have done that. I actually ended up back in Victoria and thought, I'm sweating so much in the bed sheets that the bed sheets are turning the same color as my nightgown. But anyways, I managed to make it through the cruise and back home, but the day I came back, I thought I didn't know I was septic, to be fair, but I came back and the same thing happened. I ended up unconscious at my home and in the hospital. So I ended up staying there about 17 days. Am I in the negative by 2 minutes? Oh, sorry. I wasn't watching the time here. So I was in the negative, I was in the hospital for 17 days on both occasions. And, you know, when it comes to the hospital, it's probably the place that many of us, it's the last place we want to be. And in some cases, the last place we want to be to get better. We all know what it's like in the hospital. It can be noisy, people coming and going, doing blood work, turning people in bed. Not only that, there's the secondary complications such as pressure wounds, infections, etc. None of us want to go to the hospital to get worse. We want to go to get better. So after the 17th day, I begged the doctor to let me go home, and with the proper supports, I was able to go home. So there are times when people don't need bricks and mortars to get better. A lot of us do get better in our own home, as long as there's supports available, and that's why I was so keen on being involved with the Hospital at Home project that they're working on currently. What else did I want to say? Yeah, I think I just wanted to mention really that it's getting to those voices that aren't always heard, and often you can use leaders in the community to help reach out. I was involved in quality awards and judging them recently, and I was really excited to hear about some of the innovative projects in the downtown east side, and also people who had been incarcerated in prison, helping people get back to their lives and in a holistic way. So it involved giving people cell phones and using peers to help connect. So there's some really neat projects out there, and if you can often involve people who have that experience, who are a trusted member of that community, it can help with getting recruiting and disseminating that information once you're finished. And I don't know if I have a whole lot more to say. I could probably tell you lots of stories today, but I really appreciate you listening and just being aware that there are those populations that are hard to reach, and reaching out to leaders in the community can often be a way of bridging that gap to reaching those populations.
Thank you. I mean, you're worried about the timer. We're talking about get the message. I think it's really important that we get this message versus worrying about a timer right now, you know? So thank you so much for sharing. We're gonna grab a quick picture. I'm gonna scoot this way. Ba-doot, doot, doot, doot. Over here. Awesome. Thank you so much. If everyone can give them a round of applause again. Thank you. Okay, next we're going to hear from, I will get it right this time, findings from the Northern BC project. And I will give you guys the microphone. Thank you so much.
Thank you so much. We're so honored to be here today with so many incredibly passionate people in the room and to learn from you all and to have the opportunity to share a little bit about our work. My name's Brittany Barnes-Dean. I'm the Director of Programs and Partnerships at Cassie and Friends. This is my co-presenter, Georgina Clarkson, who worked with us while she was completing her Masters of Leadership at Royal Roads University, particularly on this project. So for those of you who are just learning about Cassie and Friends, we're a national organization based in BC that focuses on working with all the major children's hospitals, specifically within pediatric rheumatology. And for those of you who are still learning what pediatric rheumatic diseases are, they're diseases such as juvenile arthritis, lupus, fever syndromes, and many more. Juvenile arthritis alone affects 24,000 kids and families right across Canada. There's no known cause, there's no known cure. And so when we're talking about this work, it's not just kind of temporary solutions we're looking for when they're cured. There is no cure. It's lifelong. 60% of kids have active disease into adulthood. Treatments for juvenile arthritis often include low-dose chemotherapy, injections, infusions, and many other challenging aspects of treatment come along with that. And that's not even factoring in the unique challenges that come with where you might live.
Thank you. Great, thanks. So research tells us that Canadians living in rural and remote communities face complex barriers to accessing healthcare. And those include things such as low physician to population ratios, the significant burden of financial cost and time spent in traveling long distances and in often treacherous conditions to reach the care that they need, and as well as limited awareness across the community with respect to lesser known health challenges. And so what we sought to do was explore how these barriers impacted the patient family members of our learning community in northern BC so that we could co-create together an increase in services and supports and advance equitable and inclusive access to care.
So our learning community, it includes several different groups, and I actually wanted to take this opportunity to illustrate how we went about building our community, our learning community. So as I mentioned, we work really closely with all major children's hospitals in Canada, including BC Children's. So the division head at BC Children's approached us after several years of going to the outpatient clinics in Prince George and Terrace to bring rheumatology care and services to families affected in that region. She asked us, would you get involved and learn about the unique challenges in accessing care for that region and potentially work with them to identify solutions? So that's when we got involved, and we quickly reached out to other healthcare professionals and organizations to hear about their perspective of the unique challenges that we're facing the regions. A note in this particular category, this work happened on the heels of the pandemic, and so there was kind of an added level of coordination needed in order for us to travel to the outpatient clinics ourselves and just make sure that some checks and balances were in place to ensure everyone's safety. And I thought that point really highlighted the importance of building relationships with the different systems and organizations involved. So once we kind of figured out the what and the who of our project, we had to figure out the how. How are we going to make this happen? So we began reaching out to community partners and project funders who were also local to Northern BC and had their own lens of what their community needed. And once we received funding, we were able to connect with 60 patient families, including youth, parents, caregivers, and support persons. In those conversations, which first and foremost took place at the outpatient clinics, 5 outpatient clinics over the course of a year, a lot of questions were asked about what resources already exist for me to access additional supports. So we then connected with 23 local support organizations and conducted an environmental scan of different supports that our families could access, ranging from travel, accommodation, mental health, financial supports that were already available, and then would help us to identify gaps for supports that weren't available. So I say all this because what started as one person coming to Cassie and Friends and asking us to get involved became 114 members of our learning community. This didn't happen overnight. This took a year. It's still growing. This work is incremental, but it's so important to keep moving with it. It also allowed us to develop an approach that was really based in fostering trust and care. All of our engagement was offered in different modalities, which I'll show in a sec. We wanted to make sure it was very conversational, not just a one-way conversation. All of the questions that we asked were optional. We approached this project from a culturally safe position, provided honorariums when we could, as we just heard about the importance of. And then also for our in-person engagement, we offered travel and accommodation support for those facing financial barriers. So these are some of the engagement activities that we utilized. I really wanted to draw attention to what's on the right of your screen and at the very bottom there. So we hosted an in-person connection and education event in Prince George. And as a result of the relationship that we built with families in the room, they felt comfortable enough to share some of the emotions they were feeling by being there. And the last 2, Seen and Cared About, I thought were really powerful, and it made me wonder if this patient-oriented approach was embedded in research and in practices of care. What impact would that have on the patient and physician relationship and dynamic? And what impact would that have on healthcare outcomes overall?
Thank you. We just wanted to share a couple of snippets of data. We won't go into huge detail, but just to provide a little extra context to this story and this journey. 70% of families who have participated so far have disclosed that they had felt that their child's symptoms were initially dismissed or overlooked, which in many cases resulted in them needing to then eventually seek emergency care. They also expanded more on the barriers and burdens that they experienced in the process of receiving a diagnosis and then subsequently accessing care, speaking about feelings of isolation and just the overall emotional component and burden that comes with their journey. And as we look at these really important pieces of information and stories that we've received, we've reflected on just how our approach in building that trust and cultivating those caring relationships helped us receive these stories to this degree from our participants. And yeah, we're not sure that if we'd have taken a different approach, that we would have been able to hear such depth from our patient, family, community members.
And just to build on that, we've also talked about, the fact that we were there on the day that they were in the outpatient clinic, on the day that they're actually experiencing these barriers and these challenges. allowed us to hear those stories in the moment, as opposed to if we would have connected with them a week after that appointment or a month or 2 months after that appointment. So we were able to get some really incredible data because of that. And I think the learning from that is to get out into the community. I know one of our previous presenters was saying, you know, we can't assume that we know what patients are experiencing. We have to get out there and we have to have these conversations with them while they're experiencing them. And so because we were so keen, I guess, on including the patient voice, we were able to develop these 4 recommendations for reducing barriers and advancing care. I'll let you kind of scan them, but the one I'll highlight just in the interest of time is elevating patient family voices. So next month in December, we're actually co-facilitating continuing medical education session with BC Children's and Northern Health with all of the family physicians that are located in the Northern BC region, so they can learn more about the early signs and symptoms of childhood rheumatic diseases, which is really important for kind of addressing those wait times and getting them more quickly into care. We know that implementing these recommendations will mean continued and central engagement with our learning community. And we also know that these challenges are not unique to pediatric rheumatology. They probably relate to a lot of your learning communities as well, and we'd love to hear how they might resonate with you. So if you think you could help, or if you think you want to learn more, you just want to chat, please reach out. We'd love to stay in touch. And with that, we just want to say thank you so much for having us, and thank you to the conference organizers. Thank you.
Thank you. Findings from the Northern BC project. Thank you so much. We are actually going to change things up a little bit. We're going to leave out the Q&As for now, but please do put your questions in the app. We're going to be having them on the website, and we will take time to go through them and answer them. So thank you so much.